Hello and welcome to the Parkinson's Foundation Wellness Wednesdays webinar. I'm Krista Ellis, Community Engagement Manager for the Parkinson's Foundation. Helping me behind the scenes are my colleagues Laura Cameron and Jenny Fearday. The Parkinson's Foundation is a nonprofit focused on bettering the lives of those living with Parkinson's through improving care and advancing research. Importantly, everything we do is in close concert with our community to ensure that our actions are aligned with the needs and priorities of those living with PD. There is much to be shared and explored in this journey of Parkinson's, and for today, we will stick to the foundational understanding of what Parkinson's is, what causes it, common symptoms, treatments, and strategies for managing symptoms. Please know this is a basic overview of Parkinson's. We have many other offerings and webinars that dives deeper into the layers of Parkinson's disease. We are recording today's presentation. You will receive a follow-up email with a link to today's recording and other resources in the coming days. The Parkinson's Foundation provides weekly education and wellness programs virtually through our PD Health at Home series, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, expert briefings, and our Spanish language programming, Y Salud en Casa. Join us for our next Wellness Wednesday on October 11th. We will be hosting an expert briefing on Parkinson's and the gut-brain connection. While stomach or intestinal distress can lead to anxiety or depression, gut-brain connections go much further. New research strongly suggests a link between the gut, the gastrointestinal system, and Parkinson's disease. During this expert briefing, we will learn more about the gut's potential impact on symptoms and progression. Find out more and register for our PD Health at Home events at parkinson.org/pdhealth. I'd like to bring special attention to our event on October 18th. We will be hosting a program designed for people living with Parkinson's who have not shared their diagnosis publicly. This webinar will highlight the challenges many people face when deciding how and when to share their diagnosis publicly. Recognizing that both cultural and financial factors come into play, the decision to come out with Parkinson's can be emotional and very personal. Attendees will hear from peers who have navigated this process and the lessons they've learned. We will highlight ways to find support without sharing a diagnosis beyond your comfort level. Please share with your community, support groups, exercise classes, or wherever you feel this program may make an impact on someone's life. They can register to receive that Zoom link anonymously at parkinson.org/pdhealth. To begin our formal presentation, we'd like to introduce today's expert presenter. Dr. de Marcaida is the Medical Director of Chase Family Movement Disorder Center of Hartford Healthcare and Associate Clinical Professor of Neurology. Under her leadership, the Chase Family Movement Disorder Center has grown from a single center, single doctor practice in Vernon, Connecticut in November 2015 to the comprehensive, fully integrated program that now exists in 6 locations all across the state and a team of 10 of the most highly regarded movement disorder specialists in the region. She has been the principal investigator for over 40 clinical trials for Parkinson's disease and other movement disorders and has authored numerous publications and textbook chapters in the course of her career. She is also the program director of the Movement Disorders Fellowship Program of the University of Connecticut and Hartford Healthcare, encouraging a future generation of young physicians to develop the skills and passion for this field. Dr. de Marcaida has a special interest in evaluating novel pharmacologic and non-pharmacologic interventions, including the role of naturopathic and complementary and alternative medicine in the management of PD and other movement disorders. She advocates strongly for a shift away from a single-minded focus on the management of disease to a broader perspective on the importance of overall wellness and well-being as a better approach to care. She is passionate about caring for her patients from diagnosis to hospice and being a true partner in the journey through a life that she aspires will be no less full despite their neurologic diagnosis. She is also fervently involved in various initiatives addressing health inequity and racial injustice at work and in her community. Dr. de Marcaida, thank you for joining us today.
Thank you very much, Krista. And I was so proud of the Parkinson's Foundation when I found out that this program this afternoon is reaching the community of people with Parkinson's disease from coast to coast. It is truly a privilege to have this opportunity to hopefully give you information that will be impactful for each and every one of you through your journey with Parkinson's disease. Those of us who are in the field have been optimistic about the many diagnostic and therapeutic options that have come up over the years and the decades that I have been in practice. PD 101, though, is one of the most difficult topics for me to talk about because we just have so much to share. And a disclosure that I will say right away is that I tend to talk too much just because there is so much that we would like to share with all of you. Having said that, because this is PD 101, what I want to highlight through the slides that I'm going to show all of you this afternoon are the things that I have heard my patients and their families say that I wish I had known that early on when I was first diagnosed with Parkinson's or in the first few years. So although there will be a lot of information on your screen, the things that I will highlight for you will be the things that I feel are going to be most important for you to hear about at this point. And of course, at the end of this talk, feel free to ask questions, and I will certainly try my best to address as many of them as I can. So, Parkinson's disease is defined by the cardinal motor symptoms of Parkinson's. And the mnemonic that we give our medical students is TRAP, standing for tremor, rigidity, akinesia or bradykinesia, which is slowness of movement, and postural instability. It is imperative to make the diagnosis that somebody who presents to us for the first time has bradykinesia. So that is the first symptom of Parkinson's that we look for, pervasive slowness of movement. In addition to the bradykinesia, we also look for at least one other of these three other cardinal symptoms of PD, either the tremor, rigidity, or postural instability. We will go through this again, highlighting the main features. T for tremor. What is characteristic of the tremor in Parkinson's disease is that it is a tremor at rest. The reason why it's important for us to emphasize that is there is a more common neurologic diagnosis that is characterized by tremor or shaking movements, and that is essential tremor. But essential tremor is different from Parkinson tremor because essential tremor occurs primarily when a person is doing things or when they are holding their arms out in front of them. So it's either a postural or action tremor, different from Parkinson's disease, where we have it when the arm or the leg is completely supported against gravity and is at rest. The Parkinson tremor tends to be a little slower. What characterizes tremor is either an oscillatory movement around a joint or a flapping movement at the wrist. And most typical is what we call a pill rolling tremor, as illustrated in this picture, where there is just that flexion, extension of the fingers with that little rotational movement at the wrist, similar to somebody rolling a pill in their hand. It's usually a 4 to 6 hertz per second tremor, but it can affect not just the hand, it can also be in the legs, in the chin, in the voice, in the lips, in the tongue, or the eyelids when the eyes are closed. Having said that, when I talk about the symptoms of Parkinson's, please know that everyone is going to be different in the symptoms that they will experience throughout the course of having Parkinson's disease. So any one of these symptoms you may never experience because we say that Parkinson's disease is a snowflake disease. Every person is unique. It's a designer disease. You meet one person with Parkinson's disease, you know one person with Parkinson's. So I am giving you as much information as I can, but some of these things you may never experience. It's always important to talk to your physician so that you can have a discussion about the particular symptoms that you are experiencing which may need to be addressed. Rigidity, the R in the mnemonic TRAP, it's mainly a finding on examination. It's increased muscle tone, stiffness of the muscle. But something that I like to point out is that many people who are eventually diagnosed with Parkinson's will say that the first thing that I experienced was shoulder pain. And they go to their physician, and it's not recognized as a symptom of Parkinson's, because more commonly people will have shoulder pain because of arthritis, because of rotator cuff injuries, and they go to an orthopedic surgeon, they get injections into that shoulder, not realizing that that was actually the first symptom of Parkinson's that they developed. And usually the Parkinson's disease symptoms occur on one side first. So the shoulder pain will just be on that one side. But the stiffness of muscles will also manifest with a little bit of flexion at the elbows, a little bit of flexion at the knees. Sometimes people have back pain, a little bit of stooping of the posture. So that is the symptom of rigidity. Bradykinesia, like I said, this is the main symptom of Parkinson's, usually the most disabling, the most bothersome for people of the four cardinal features of Parkinson's disease. It's particularly manifesting when people are doing repetitive tasks, so brushing your teeth, combing your hair, getting money out of the wallet, but there is a restriction of fine motor dexterity, coordination. Many people will say, usually the loved one is the one who will notice, I noticed that my loved one wasn't swinging one arm when he or she was walking. So that is another early symptom of Parkinson's. But the slowing of walking, the slowing in everyday tasks takes you longer to get dressed, finish a meal because of this symptom of bradykinesia. Sometimes the physician might think that the person had a stroke because, like I said, Parkinson's usually affects one side of the body first, and that arm is not swinging on that side, that foot is dragging in that one leg, and the physician, who may not immediately recognize Parkinson's, will think, well, maybe this person had a stroke. But the difference between Parkinson's disease and a stroke is a stroke happens just like that, overnight, very acute onset. Parkinson's progresses over time. There is also a slowness of the facial muscle movements. So people will say, my loved one doesn't smile as much anymore. There's a masking of the facial expression. The vocal cord muscles are slower, so there is a softening of the voice. There is slowing of the movements of the hands when people are writing, so the handwriting gets smaller. So these are symptoms of Parkinson's disease that constitute the problem with bradykinesia. The last cardinal symptom is postural instability, loss of balance. This usually occurs in the mid to late stages of Parkinson's. But again, as I said, everyone is different. And some people with PD will say that my balance was affected very early on before I was diagnosed. But the reason for the balance impairment is there is a loss of the automatic ability that we all have to correct when there is a challenge to our center of gravity. So you'll notice that when you trip, so you're falling forward, automatically your dominant foot is going to step forward to correct that postural imbalance. With Parkinson's disease, because there is a slowness of movement, there is a slowness in that reflexive action, that ability to correct when there is a challenge to your center of gravity can be affected. And then you are at greater risk for falls. There is also that stooping of the posture or sideways tilt of the trunk that also affects the center of gravity that can lead to the postural instability. I already disclosed that I talk too much, right? So just talking about the cardinal symptoms, there we go. A lot of information, but just the main things for you to remember. More than this, however, these cardinal motor symptoms that I just talked about is just the tip of the iceberg. So these are the symptoms that people will see. What is frequently much more challenging for people who have Parkinson's disease are the rest of these symptoms, the non-motor symptoms of Parkinson's. I said that the main thing that I wanted to share with all of you today are the things that I have heard from my patients. I wish I knew that. And the talk on non-motor symptoms of Parkinson's is a whole talk in and of itself. But for you to at least hear from me, if for the first time or the second time or the first or the third time, that these are symptoms that you could be experiencing that you may never think has anything to do with your Parkinson's, but is actually a huge part of the presentation of Parkinson's disease as well. Constipation. People will say, I have had constipation decades before I was ever diagnosed. And we now know that these non-motor symptoms can occur many years before the motor symptoms of Parkinson's. We call that prodromal Parkinson's symptoms. They occur before Parkinson's manifests with those four cardinal symptoms. Loss of sense of smell, loss of sense of taste, drooling, bladder issues, sleep problems. People either sleep too much or can't sleep, or they have active dreaming where they're acting out their dreams at night, talking or screaming in their sleep. This can occur years before people are diagnosed with Parkinson's. Depression, anxiety, cognitive slowing. So we call it dementia, but please know that dementia in Parkinson's is different from Alzheimer's disease. With Parkinson's, in the same way that the physical movement slow, the dementia or cognitive impairment in Parkinson's disease is slowing of cognitive processing. So people with Parkinson's disease are usually highly intelligent, very high functioning people. And they used to be able to multitask. They can do 10 things at the same time. But with the onset of Parkinson's, now it's more difficult to multitask. They have to think about things that came very intuitively and instinctively for them that they've been doing for years. Executive function can be affected such that now thinking through the logic of a complex task has to be broken down into single step-by-step measures in order to figure out that task. So that is the sort of cognitive impairment that can occur with Parkinson's, different from Alzheimer's. Hallucinations, seeing things that aren't there, paranoid delusions, most commonly spousal infidelity. These are things that, again, someday, if you are one of those who might develop these symptoms, don't be afraid to share it with your physician. Because some people will say, I didn't want to say that I was seeing little mice under the table because I didn't want them to think I'm crazy. But these are symptoms that are part or can be part of your Parkinson's and can be treated, can be corrected. So it has to be expressed, has to be shared with your physician and your loved ones. Apathy is very challenging. It's that loss of motivation and interest. Orthostatic hypotension, people get lightheaded when they stand up because their blood pressure drops. Excessive sweating, people will share with me that at night I am just drenched. My shirt is drenched and I have to change twice a night. That can also be part of Parkinson's disease. Pain, restless leg syndrome, blurring of vision, things that people would never have thought to discuss with their Parkinson's doctor. But it's actually a huge part of what people experience with Parkinson's. And why is that? So we all know that Parkinson's disease is primarily a dopamine deficiency. So there is loss of these brain cells in the part of the brain called the substantia nigra or the basal ganglia right here, which is the primary producer of dopamine in the brain. So if those brain cells get sick with Parkinson's, then your brain is not producing enough dopamine for the functions that it needs to enact in the body, which is primarily movement. But in addition to the dopaminergic cell loss, look at all of these other parts of the brain that are also affected by Parkinson's, which affects so many other neurochemicals in the brain with so many other functions. So there is loss of serotonin, there is the effect on acetylcholine, there is the effect on norepinephrine or noradrenaline, And those are the neurochemicals that are essential for blood pressure, that can affect and cause constipation, that can cause depression and anxiety, that can cause cognitive impairment. So if now we know that all of these other brain cells are also affected and there's a loss of so many other neurochemicals besides dopamine, then you can understand why there are all of these other non-motor symptoms. And this was what I was referring to. What we know now is that at the point of diagnosis, which is here, when the motor symptoms have started to manifest, before that, there are all of these non-motor symptoms that can also occur. But look at what's happening. Even before the onset of the prodromal non-motor symptoms, the loss of those dopaminergic brain cells are already occurring decades before the diagnosis. And that's why one of the things that we'd like to share with people who are just diagnosed with Parkinson's disease is that by and large, Parkinson's disease is a slowly progressive neurologic condition. You have probably been living with it for years or decades, and yet the symptoms that you're experiencing right now may be mild. So if you do things right and be a proactive advocate for your own wellness, you can do well with Parkinson's for many more years. And those are the things that we are going to talk about today. What do I have to do so that I am empowered to try to prevent the progression of Parkinson's disease so that I can stay well despite my Parkinson's disease for as long as possible, live my life fully for as long as I can, with the medications that we have available and the things that you will do for yourself to stay well. So the medical management of Parkinson's disease, because I shared with you that it's primarily a dopamine deficiency, focuses on replacing dopamine. The wonderful thing about the field is that we have found that there are so many ways that we can enhance dopamine in the brain. And that's why, to date, we have 33 medications for Parkinson's disease. Isn't that phenomenal? We cannot say that for too many other neurologic conditions. But for Parkinson's disease, we are so proud to say that we have so many pharmacologic treatment options that address the dopamine deficiency in different ways so that they can be complementary to each other. So we have certain medications that we can use early when people are just diagnosed. And as the Parkinson's progresses, there are so many additional medications that we can add on to enhance the gold standard treatment for Parkinson's disease, which is levodopa. In addition to this, I will be sharing with you that there are also surgical options for Parkinson's disease if medications are no longer doing what they need to do to keep the PD symptoms under control and to keep you going, doing the things that you love to do and that you need to do throughout this condition. So you can see that there are many ways that we talk about it: initial medical therapy, subsequent medical therapy, and advanced therapies for Parkinson's disease. But look at this side of my slide. Throughout your course of Parkinson's disease, please talk to your physician about physical therapy, occupational therapy, speech therapy. Because as I shared with you earlier, Parkinson's, the motor symptoms of Parkinson's can affect your fine motor movements, right? So it can affect your ability to cut your meat or to write more legibly or to do repetitive things, keyboard, which is crucial for many of our jobs. The occupational therapist can try to help with exercises and with strategies so that you can overcome the limitations posed by the Parkinson's on your coordination and dexterity. Physical therapy will help with strengthening, balance, endurance, exercise. Please, 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 please exercise. In the last 10 years, we have found there was a boom in the research establishing that exercise can slow down the progression of Parkinson's disease, and exercising more can give you benefits even more. So, what that means is it doesn't matter what exercise regimen you choose something you enjoy, choose something that you're going to do regularly, because all of them in the research studies have shown benefit for progression or slowing down progression of Parkinson's disease. Furthermore, more recent studies have shown exercising for 10 minutes is better than not exercising at all. Because initially, when we were talking about exercise, we were telling everybody you have to hit moderate to vigorous intensity exercise 150 minutes per week. So that's 30 minutes 5 times a day or an hour 3 times a day. One way or another, you have to hit 150 minutes per week. And it has to get to vigorous or moderately intense exercise. And that was difficult for some people to do. So it was so reassuring when we found more recent literature showing that even if we exercise for 10 minutes a day, and even if we can only get our heart rate up so much because it's mild to moderate intensity exercise, there are still benefits. But if you can build that up so that as you exercise 10 minutes a day for the next 6 months, after that, you're able to do 30 minutes a day or 15 minutes a day, 20 minutes a day. So you keep building up your exercise regimen so that you get to more intense levels, then that will be superb. So we'll talk a little bit about treatments. But like I said, we have so many medication options, right? And I'm going to run out of time if I talk about each one and all the information I'm presenting in the slides. So let me just highlight a few things. Anticholinergics, that's benztropine or cogentin, trihexyphenidyl or artane. If any of you are taking that, this is one of the first medications that were ever discovered as a potential treatment for people with Parkinson's disease. The earliest report of use of anticholinergics was from 1867. And the reason why that is interesting to us is because levodopa, which is the gold standard treatment of Parkinson's, was not discovered until 1967, so 100 years later. So for the longest time, anticholinergics were it. However, we don't use anticholinergics too much anymore. It's an old drug. So there were a lot of side effects when it was first formulated. People who are a little older may experience these side effects even more commonly than younger people. Memory impairment, confusion, hallucinations, it makes them sleepy, dry mouth, blurry vision, constipation getting worse, urinary retention, especially for men who have prostatic enlargement. So it's difficult to use this medication, but there are some physicians who will prescribe it, particularly for younger people with Parkinson's disease, and particularly if their main symptom is tremor. It seems to be particularly helpful for tremor. It seems to be particularly helpful for dystonia, which is a muscle spasm, muscle cramping. Sometimes the toes are curling in their feet, or there is cramping of their arm, or for drooling. So, for these particular symptoms, anticholinergics seem to be more helpful. However, if there are side effects, then of course it needs to be discontinued. MAO-B inhibitor is another class of drug that can be used early in the diagnosis of Parkinson's disease. These are rasagiline, selegiline, and safinamide or Xadago. Rasagiline or Azilect is the only one that's actually FDA approved as initial treatment for Parkinson's disease. It's mild in its effect on the motor symptoms, but on the flip side of that, the other good part about it is it's also mild in terms of the side effects. There was also evidence that rasagiline might slow down progression of Parkinson's disease. Selegiline is sometimes used, particularly by some physicians, because it is broken down into amphetamines. So the amphetamine can help with people who have sleepiness and might need a little pick me upper because amphetamines are stimulants. Xadago is the other MAO inhibitor, and that can be used as an add on therapy for levodopa. Something that those of you who are on an MAO inhibitor may hear from their physicians or their pharmacists is that, well, you can't take cough medicine because you're on this medication, rasagiline. You can't take antidepressants. You can't eat cheese, blue cheese, and you can't have red wine. So this is not true. If you hear this from your pharmacist, please tell them to talk to your physician, because what they're referring to is an interaction of non-selective MAO inhibitors with these other medications and with certain tyramine-rich foods. The MAO inhibitors that are used in Parkinson's disease are MAO-B selective inhibitors. And because of that selectivity, it actually has a very low risk of these interactions with food and drugs. So that's a little highlight for those of you who are on MAO inhibitors. Dopamine agonists, ropinirole or Requip, pramipexole or Maripex, fluticasone or Nupro. Nupro is the only patch formulation of medications for Parkinson's disease. And apomorphine or Apoquin, which is an injectable, like an insulin self-inject, or those of you who have migraines. Some people do injections for their migraines. So Apoquin is a dopamine agonist, but it's special because it's a rescue medication, and I will explain what that is a little later. So dopamine agonists are mid-potency medications, not as potent as levodopa, but certainly more potent than the other drugs. The thing about dopamine agonists is they pretend to be dopamine, so they bind with the receptors, and the brain cell thinks that they got dopamine, and they're able to function and overcome the symptoms of Parkinson's. Specific concerns for those of you who are on dopamine agonists: if you are experiencing sleep attacks, nodding off in the middle of a task, that could be your dopamine agonist. Also, something to remember for those of you who are on dopamine agonists: if you notice, or your loved ones notice, that you are now gambling where you never gambled before, you are now spending a lot more on Amazon, you have hobbies that you cannot control, these are called compulsions. Impulse control disorders is a side effect of dopamine agonists that is sometimes not recognized until somebody heard somebody talk about this and say to their physician, hey, I have developed a gambling problem. You have to come off your dopamine agonist. Or sexual compulsions. People who have always been honest and faithful, all of a sudden are on pornography sites. So these are things that can occur as a side effect of the medication. It's not you, it's your medication. So if that happens, again, it doesn't happen to everyone, but if it happens, know that it's something that you have to talk about with your physician. Levodopa is the gold standard treatment of Parkinson's, the best medication for Parkinson's disease. It is direct replacement of the dopamine. So the relevant information that I want to share with you is that levodopa is formulated as a combination of carbidopa and levodopa. So it's carbolevo, some people call it, carbilevo. The important dosage that you have to share with your physician is the second number. So it's how much levodopa is in your medication. So it doesn't matter that it's 25 or 10 or 50. What matters is that second number, and that's the amount of levodopa that you're taking. So if you see that your pill says 36.25/145, what you're going to tell your physician is you're taking 145 milligrams of levodopa. Because it's the best medication for Parkinson's disease, investigators have tried to develop multiple formulations of levodopa, trying to make it better and better, faster onset, more consistent efficacy, more stable plasma levels, so that people can have more effective treatment of their Parkinson's disease symptoms over time. So these are all the formulations of levodopa that we have. Most of us know that yellow pill, that's Cinemet, but there's also Parcopa that melts in your mouth. Rytary, which is a combination slow release and fast release capsules. Divi, which is a levodopa that you can divide into 4 little quarters. Ambrosia, which is an inhalable formulation of levodopa, another rescue medication, which I will touch on briefly. And there is even continuous infusion of levodopa through the intestinal, as an intestinal gel. So through PEG-J or J2, but that is continuous supply of levodopa throughout the day. So this is the inhalable levodopa. This is the combination slow release and fast release levodopa. This is the little formulation of levodopa that you can cut into tiny little quarters. And this is the infusion intestinal gel levodopa. So I was starting to talk about all the different classes of drugs, right? And the reason why we have so many classes of drugs is what I said. There are so many ways of enhancing dopamine. So this is how a dopamine agonist works. It binds with the dopamine receptors, pretends to be dopamine, and therefore that brain cell is able to function and send the signals along to our muscles. An MAO inhibitor prevents the breakdown of dopamine because MAO enzymes are the enzymes that break down dopamine. So if you inhibit the enzyme, then there's more dopamine to be had. The COMT inhibitor, which I will talk about later, is another enzyme that breaks down dopamine. So COMT is an enzyme that breaks down dopamine. A COMT inhibitor stops that enzyme from breaking down dopamine. There's more dopamine to be had. Levodopa, the main treatment for Parkinson's disease, you get it into your gut, it crosses the blood-brain barrier, it gets into the brain cell, is directly converted into dopamine. So that's why it's the most potent medication for Parkinson's disease. So something to remember when people are on levodopa, that in the early stages of taking levodopa, people will say, hallelujah, my symptoms have completely disappeared. It's that honeymoon period where levodopa is so effective in treating the symptoms of Parkinson's disease that they feel that they have overcome all of the symptoms. So this mint green area is called the therapeutic window. And you can see that people are taking their levodopa first thing in the morning, sometime in the mid afternoon or at noontime, another time at dinner time, just 3 times a day, and they feel good all day. They are in that therapeutic mint green area of the pharmacokinetics of the drug throughout the day. However, after a few years, there are people with Parkinson's disease who will find that now they take their levodopa, but then after a few doses, they go outside of the therapeutic window. The levodopa doesn't seem to be working. So when you see these areas underneath that therapeutic window, those are the times when the medication doesn't seem to be working. In addition to that, there are times that they're going to feel that their medication is too much and they go above the therapeutic window and they develop a symptom called dyskinesias. So in the middle stages, people start noticing, okay, now I can't last 6 hours anymore. Before the 6 hour mark, I notice my symptoms are coming back. So that's called wearing off. And they have to dose more frequently now. So now they have to take it every 4 hours instead of every 6 hours. As they continue with the Parkinson's disease and have been taking levodopa even longer, now you see that they have to dose even more frequently and they have to be more precise in their dosing. Every 3 hours, they have to take the pill because otherwise they're going to be in this off state so many times during the day. In addition to that, there may be times when they're going to be more disconnected during the day. So that therapeutic window is narrowing over time. And that's why it's important that we have so many other options to add on to the levodopa when that happens. So the manifestations of motor fluctuations, which were the ups and downs that I just showed you, and the motor complications are these. So these are examples of the things that people who develop motor fluctuations might experience. Again, not everybody will, right? But if you do experience it, you can experience wearing off, meaning that you take your levodopa and it used to last 6 hours, now it only lasts 4 hours. After a few more years, it only lasts 3 hours. For some people, it only lasts 2 hours. So that is wearing off of the medication effect. There are some people who will experience delayed on. They take their medication, it's already an hour, it still hasn't kicked in, an hour and a half, it still hasn't kicked in, and then suddenly they feel better. Normally, levodopa should kick in 30 to 45 minutes. So if there is longer delay to kick in, then that's a delayed on. There are dose failures where somebody takes their levodopa in the middle of the day, their second or third dose, it doesn't even work for the whole 3 hours that they have that dose supposedly working. It completely fails. So there is no on. That's a dose failure. And this is the most challenging, random ons and offs. No rhyme or reason. They're taking their levodopa exactly on time. But for some reason, they just wear off in the middle of it when it's supposed to be working. And even if they don't take another dose, all of a sudden they feel better. So it's that unpredictability of the dosing that gets very challenging. So, words to remember so you can have conversations with your physician. Some words that I already threw out there. I am in the on state. I am on for so many hours of the day. What that means is that you are in that green area. You are feeling good. Your symptoms are under control. How long does that last? What time of day do you feel on? These are the things that you can share with your physician so that they can help manage your medications a little bit better. So the on state is when your medication is working, your Parkinson's symptoms are under control. Then there is the off state. The medication doesn't seem to be working. Your Parkinson's symptoms come back, whether it's tremor, slowness, difficulty getting up from the chair, shuffling of gait, stooping of the posture. These are the symptoms. Everyone is different, but these are the symptoms that people experience when their medication has worn off and they are in the off state. But remember, when I was talking about the non motor symptoms, there are some people with Parkinson's who will not experience so much of the motor symptoms or the tremor. They're going to experience the non motor symptoms when they're off. So, in their off state, they feel, I just feel foggy headed. I just can't think straight. I'm not talking well. I feel sleepy. I have pain around my abdomen. I'm having shortness of breath and I'm breathing rapidly. Or I have a panic attack. Remember when I was talking about all of those non-motor symptoms of Parkinson's? People can experience that as an off phenomenon. So if you notice that you're having these non-motor symptoms that seem to be related to the times that you take your medication, then express to your physician that I might be experiencing an off period. And these are the manifestations. Okay, on with dyskinesias. Remember when I said that when you're above that mint green area and you feel like you have too much medication? People have dyskinesias. What that means is they have involuntary movements, but they're different from tremor. Tremor is an oscillation, rhythmic movement. Dyskinesias is more like dancing. So they're correct movements, they're irregular movements, or fidgeting of their legs, fidgeting of their arms. So these are involuntary movements that occur because now the levodopa gets too much into the system and it activates the dopamine receptors too much. And now they have too much movement. A lot of people who have dyskinesias will say, I don't even notice my dyskinesias. It's the family members, the loved one, the friend who might see these involuntary movements. But at that time, they're actually feeling good. The person with Parkinson's disease actually feels good because they're in the on state. Their medicine is working, except that it gave them a little bit of a fidget. So sometimes we don't bother to treat dyskinesias, but it's something that you want to still report to your physician if you are experiencing it, especially if the dyskinesias are a little bit too much. So the things that we do when people start experiencing these motor fluctuations and complications like dyskinesias is to adjust the levodopa dosage. So either you increase the amount of levodopa that the person is taking, or you have to ask them to start watching the clock and take the levodopa at a particular set interval of time, so a set schedule. And if that happens, it becomes really important that you follow the schedule. In addition to that, you can add those medications that I talked about earlier. You can add the MAOB inhibitors. You can add the dopamine agonists, all of the ones that I discussed later. And remember, I talked about that other enzyme that breaks down dopamine. So COMT inhibitor stops that enzyme from breaking down dopamine, and it can be added onto levodopa so that the levodopa will last longer.
The thing to remember about COMT inhibitors is that you can't take it on its own. It can only be taken when someone is already taking levodopa. So if you take entacapone or tolcapone or opicapone on its own, it has no benefit to you. It's only beneficial if you're already taking levodopa. So these are the three COMT inhibitors: entacapone, Comtan or Salivo, tolcapone or Tasmar, opicapone or Ongentys. The specific concerns with these medications, tolcapone or Tasmar is hardly ever used anymore because early on, when it first came into the market, there was a very small population of people who developed liver toxicity. So if you are taking tolcapone, you have to monitor your liver enzymes on a regular basis. Tolcapone and entacapone can cause diarrhea, and all of these medications can cause a drop in your blood pressure, leading to lightheadedness, and in some occasions can even lead to a faint. So if you're experiencing these symptoms, talk to your physician. Istradefylline or Norians is a new medication that can be added on to levodopa when people are developing the motor fluctuations. But the reason why this was so exciting for us when we were part of the clinical trials and when it came out to market is the first non-dopamine based medication that was approved by the FDA for Parkinson's disease. So there are two ways that we're able to control movement. We either give our body more dopamine, so that's like stepping on the gas pedal, or we release the brake. So istradefylline or Norians is like releasing the brake. So there is a direct pathway by which our brain signals to the muscles that it has to move, and there is an indirect pathway. So it is this indirect pathway, which is non-dopamine based, by which Norians works. NMDA receptor antagonists, particularly amantadine. The formulations are amantadine or Simitrel, Gocovri is a capsule, or Osmolex, which is amantadine ER. Amantadine is primarily used for people who have dyskinesias, so it is FDA approved for treatment of dyskinesias. However, early on in Parkinson's disease, sometimes physicians will prescribe it if, again, the primary symptoms are tremor or dystonia, similar to the anticholinergics. Specific concerns with amantadine: it is a little bit of a higher incidence of developing confusion, hallucinations, the neurocognitive side effects that can occur with dopamine medications. Also, leg swelling can be a side effect of medication, particularly amantadine and dopamine agonists. And it can also cause the symptoms similar to the anticholinergics because it has anticholinergic properties: dry mouth, blurred vision, and urinary retention. So I said I'd talk a little bit about rescue medications. And those of you who are early in the diagnosis, this may not be pertinent, but just so that someday, if you have symptoms of ons and offs and you feel that your symptoms are not well controlled, you might remember once upon a time I heard this webinar and the doctor was talking about rescue medications. So ask your doctor about it. There used to be three, now there's only two. The apomorphine or Apokyn is a subcutaneous injection, and I talked about Ambrosia, the inhalable formulation of levodopa. What's different about these medications is because it's inhalable or an injection, much more quick in its onset of action. Within 10 minutes, people who are in an off state will feel that, oh boy, I'm on again and I can function again. So it's a medication that you can take in addition to your regularly scheduled medication, for those times when you might be in an off period and you're in the middle of a ball game and trying to enjoy your child's recital or your grandchild's recital, and you get into an off state and you want to stay, get yourself that little injection or get yourself that little inhaler, and you get back into an on state. The third rescue medication has been taken out of the market. So I like to show this illustration just because I want to share with people all the options that we have available, different mechanisms of action, complementary in their action. So your doctor might be prescribing 3 or 4 different medications because they all act differently. Advanced therapies, just so you know that they're out there. We have the levodopa gel that I talked about. Continuous infusion of levodopa can be discreetly worn. Deep brain stimulation surgery, the most dramatic treatment that we have for Parkinson's disease. It's like a pacemaker, except that instead of putting the pacemaker in the heart, you put the pacemaker in the brain. You have a little computer chip in the chest. Your doctor is able to program it so that we get the best effect from stimulation, and it controls the Parkinson's symptoms beautifully. And the newest option, non pharmacologic option for Parkinson's disease, is high intensity focused ultrasound. This is very early in its development for Parkinson's disease. It's been around a little longer for essential tremor, but it is a non invasive, so incisionless procedure that creates a lesion in the brain that controls the symptom of Parkinson's disease. So, unlike DBS, we call this a non surgical option, but it's still, in a way, invasive because we have to get those sound signals in there and create a lesion that will control the symptoms of Parkinson's. As of this moment, it is only approved for the tremor control symptom, the tremor control in people with Parkinson's disease. So, in summary, we have all of these treatment options for Parkinson's disease. We have physical therapy, we have exercise, eat healthy, by the way. I always like to say the key in managing the illness of Parkinson's disease is enhancing wellness. So, do everything that you can to stay well, and your illness of Parkinson's disease will also be better controlled. Eating healthy, a Mediterranean diet, healthy oils, avoid with starchy junk food. You know, sugary, starchy stuff are actually toxic to our brain cells. There is no role for soda in our food pyramid. And replacing red meats with fish and shellfish is better. Fruits and vegetables are a must. So, all overall wellness. In addition to that, the optimism that we have in the field is that every couple of years a new medication comes out. But look at what it takes for us to get you one more medication for Parkinson's. There would be 5,000 to 10,000 compounds that are considered by bench scientists all over the world. Of this 5,000 to 10,000 compounds that are thought to be potential treatments for Parkinson's, only 250 will enter the animal studies, the preclinical testing. So when you hear NBC News, CBS News saying breakthrough in Parkinson's disease, a cure for Parkinson's disease in fruit flies, those are in the preclinical tests. We don't know how that's going to pan out because of the 250 compounds that enter preclinical testing, only 5 will enter human clinical trials. And of those, only 1 will finally be approved by the FDA because it's proven itself effective in humans with Parkinson's disease in specific doses. But the future, that is the focus of research right now, are targeted therapies. And we are hoping that targeted therapies can be more impactful in preventing the neurodegeneration that causes Parkinson's. I did disclose from the beginning that I talk too much. There's so much information to share, but I hope that in the 45 minutes that we have been together, that there's information that you heard that can make a difference in your lives. We have a lot of optimism in the field. We want you to live your life to the fullest despite this diagnosis. So talk to your physicians so they can help you, and be an informed patient advocate. Be an informed advocate for your loved one so that your physicians can help you do the best that you can with your Parkinson's. Thank you very much for your attention.
Thank you. Thank you, Dr. De Marcaida. Really appreciate the knowledge, the time, and the passion that you so openly share with our community in your presentation. So thank you. We do have a few questions before we end the webinar today. So Daniela, she asks, since Parkinson's is caused by a dopamine deficiency in the brain, what if you ate foods rich in dopamine? Thinking about vitamin supplements and other therapies such as B1, does this sort of perspective benefit our Parkinson's?
So, in our program, we would very much like to partner with people who would like to explore the naturopathic options for managing Parkinson's. The only thing that I would like to share with you is there's a lot of things that we consider natural supplements that can also have adverse effects. So you absolutely have to talk with your physician before starting treatments, even vitamin supplementation. So I don't even recommend multivitamins to people or B complex vitamins to people unless they have a deficiency, because even these vitamins can cause toxicities. And if you're eating healthy, you're actually getting all of the vitamins and nutrients that you need from your food, from your fruits and vegetables and healthy grains and healthy fats. So you only need to take vitamin supplementation if you have a vitamin deficiency. There are some naturopathic options such as mukuno, that or kava kava that contain dopamine. But again, just because it's natural doesn't mean that it's going to be harmless. You can take too much kava kava and now you're going to have a dopamine toxicity. You can take too much mukuno and now you're going to have side effects. So you have to always do it in conjunction with your physician.
Thank you for answering that question. Niall asks us, how does Parkinson's disease look different from atypical Parkinsonism disorders?
Yes, a whole topic again on its own, right? So Parkinson's disease, and I talked about the cardinal features of Parkinson's. Atypical Parkinsonisms or Parkinson's plus syndromes have those motor symptoms of Parkinson's plus. So it's Parkinson's disease motor symptoms plus significant cognitive impairment. That would be Lewy body disease. Parkinson's disease symptoms plus a lot of blood pressure issues and autonomic dysfunction, urinary symptoms, excessive sweating. Those are autonomic symptoms. So that is multiple systems atrophy. Parkinson's disease plus significant loss of function in one arm, cortical symptoms on one side. That's corticobasal ganglionic degeneration, CBD. Parkinson's disease plus loss of movements of the eye muscles, significant postural instability. That's progressive supranuclear palsy, or PSP. So when I talk to my patients about atypical Parkinsonism, I say that these are the Parkinson's cousins because it's Parkinson's disease plus these additional features.
Thank you for offering that context, Dr. Marcaida. We have a question. Do you have any words of wisdom or guidance or tangible tips for those who are coping with receiving their diagnosis and feeling scared when they witness the severe symptoms of others?
Yes. So the diagnosis of Parkinson's disease, it's something that a lot of people come to me with, and they're telling me, I was hoping that that was not what you were going to tell me. But I've already shared with you a little bit of what I tell my patients too. There is so much optimism in the field. We have so many treatments for Parkinson's. We can keep you well with your Parkinson's now. It's not the Parkinson's disease of your grandparents. We have so many options now, and all of the things that you can do for yourself to try to help yourself do better over the long term. In addition to that, people sometimes don't want to go to support groups because they see that other people are more impaired than they are. What I share, thank you for asking the question about atypical Parkinson's earlier. A lot of people who might be in wheelchairs or might be having a lot of trouble in that support group may not have Parkinson's disease. They may have that more challenging form of Parkinson's. They might have a Parkinson's cousin, and that's why they're in a wheelchair. So they all go to the Parkinson support group because they're cousins, they're family. But that is not your future. That is not necessarily your future.
They may have a condition that is completely different from yours. So do everything that you can. Power is in your hands. Work with your physician and do as well as you can. It is a slowly progressive neurodegenerative disorder for which we have many treatments.
Thank you, Dr. De Marcaida. Really appreciate your knowledge and time you're sharing with our community today across the globe. Before I close, I just want to ask if you would like to share any final statements before we go through our ending.
Yes, yes. Again, it is truly a privilege to be in your living rooms, in your offices, wherever you may be watching this webinar today, to somehow have been a part of your life for these few minutes in your journey with Parkinson's disease. But do have the confidence that those of us in the field have so much to offer you. Do as much reading as you can. Join the Parkinson's Foundation and avail of all of the resources that they have. They are a tremendous resource for the community, the global community of people with Parkinson's disease, and they are fighting this fight with you. So take advantage of everything that they have to offer. Learn as much as you can. Empower yourselves so that you can continue to do well. And God bless you and your families. I would like to give a shout out to all the people who love people with Parkinson's. Because this is a journey and a fight that we all share, and we will win it together.
I don't really think I can say much after that. Thank you so much. Dr. De Marcaida, really appreciate again your time, your knowledge, and the passion that you exude for our community here. We're living with Parkinson's and impacted by Parkinson's. And a huge thank you to all of you who joined us today to embrace what may be new for you or to come back to the basics of Parkinson's disease. Please know that a follow-up email will be sent with a survey. Let us know what you thought about today's program. You'll also receive a link to today's presentation with additional resources. So any questions that you may have had that went unanswered or was unrelated to our topic today, we'll have some follow-up resources for you in that email. If you had a question, again, that was not able to be answered, please reach out to our helpline by calling 1-800-4PD-INFO or emailing helpline@parkinson.org. You can use that same contact information to order our free resources, educational book series, and our hospital safety kit. We thank you for joining us today and hope to see you again soon. Be well.